Okay, we can start. Thank you. Well, welcome everyone to the Commandment 8 evening. We are elated that you are able to join us on this evening. Again, we are completing, or hopefully the 8th commandment, the 10 commandments of recruiting African Americans into clinical trials. I am Dr. Maisha Standifer, Director of Population Health at Morehouse School of Medicine and the Satcher Health Leadership Institute. And this evening's commandment is thou shalt build opt-in and out opportunities specifically targeted to the African American community. We'll talk a little bit further about this particular commandment, but now we'll turn it over to Mr. and Mrs. Ed and Pat Sanders.
Let's all bow our heads for a second. We want to say, Father God, thank you so much for allowing us to put on this wonderful program with Dr. Standifer and all of her guest speakers as well. Bless us all one by one. Bless us individually. Let this be a successful and a happy event. Stay with us throughout. Keep your arms of protection around us. For this we say thank you. Amen.
Maisha, Dr. Maisha Standifer. Knew her before she was a doctor. And she is so special. I think she truly represents, and I say to Maisha, God has no boundaries, and with him, neither do you. Now, let me have a couple of words about Dr. Standifer. Just a couple, because she will show her stuff now. Dr. Maisha Standifer is Director of Health Policy, David Satcher Health Leadership Institute at the Morehouse School of Medicine. She has over 20 years experience in applied social science and public health. She became a 50 Hoops legend in 2021 because she represents all that we all embody in patient and medical education, clinical trials, and helping diverse and disadvantaged populations. She has written grants. She has conducted research programs. It is no end, as I say, boundaries to what this young woman has done since we have known her. And we expect continuing great things from this great woman. Thank you so much, sweetheart. It's your show.
Thank you. Who can compete with that introduction? Thank you. Welcome everyone this evening, and I will start to share my screen. Okay. Again, so what I highlighted earlier is that we're here this evening to talk about the 8th commandment, and it's thou shalt build opt-in and opt-out opportunities specifically targeted to the African American community. And so these commandments were created by Ed and Pat Sanders to talk about the recruitment efforts, the educational and the training efforts that are being led by community-based organizations and researchers. Evening, I have an illustrious set of panelists who will come and discuss community-based opportunities, current research, and mentoring and training opportunities that are existing. When we talk about vulnerable communities, those who are medically underserved, and more specifically African Americans, and we're targeting this evening talking about lung cancer and those who are particularly at risk for lung cancer. And again, when we talk about this population, we have to understand that it is not kind of siloed in terms of what's happening within this population. We know that we have syndemic efforts that and distribution of disease that is occurring when we talk about kind of the triple-headed monster. As I was talking with Pat last week, I said, this is not unique when we talk about clinical trials and the hesitancy and the fear of being in clinical trials by African American population. And how do we, get beyond this? What are some of the barriers and what are some of the challenges when we talk about clinical trials, not just with cancer, but we're talking about HIV, we're talking about monkeypox more currently, and even COVID. And so, and this is going to be very relevant in terms of what we need to do, more so when we're talking about lung cancer and clinical trials. And so hopefully I will be able, and the panelists will be able to shed light on some successes and how to overcome some of these challenges or barriers when we talk about opting in and opting out, and being culturally relevant and intentional when we talk about recruitment efforts for African Americans into clinical trials. So to start out, I'd like to highlight a few facts when we talk about lung cancer. This evening, we are going to highlight the challenges and some barriers, but then there are some successes when we're talking about lung cancer research. The fact is, lung cancer is the leading cause of cancer death in the United States. Each year, more people die of lung cancer than colon, breast, and prostate cancers combined. Maybe speaking to the choir, but some people don't know that. Many people don't know that. Black men are about 12% more likely to develop lung cancer than white men. Black and white women have lower rates than men, but the gap is closing. Lung cancer rates have been dropping among men over the past decades, but only for about the last decade in women. And the number of new lung cancer cases continues to decrease, partly because of, the reduction in smoking, some of the cessation programs, but looking at the increase in advances in early detection. We're talking about screening, right? We're talking about research, community-based research leading to more education and even more interventions. And we'll talk a little bit about that this evening, and treatment opportunities with biomarker testing as well. And I will, as I talk about introducing my illustrious panel this evening, we will start off our discussion with our three panelists, Dr. Rohan Jeremiah. Dr. Jeremiah is the interim Associate Dean for Global Health and Associate Professor in the Department of Human Development Nursing Science with the University of Illinois, Chicago. He received his BS in anthropology from Michigan State University, his MPH in health behavior and health education from the University of Michigan, and his doctorate in applied anthropology from the University of South Florida with postgraduate studies at the University of Michigan School of Public Health. Dr. Jeremiah is a founding member of Public Health Action Support Team, a global initiative that assists local, state, and international health departments and organizations on public health events, disasters, and investigations. And Dr. Jeremiah is here to discuss a lung cancer intervention occurring in Chicago, Illinois. Following Dr. Jeremiah is Dr. Desiree Rivers. She is an assistant professor in the Community Health and Preventive Medicine Department and the Director of Undergraduate Medical Education at the Morehouse School of Medicine. She received her Bachelor of Psychology degree from Vanderbilt University and MS in Public Health from the University of Alabama School of Public Health, and her Doctor of Philosophy degree from Texas A&M University with postgraduate studies as a fellow at Moffitt Cancer Center. She is currently focusing on prevention, treatment, and survivorship research and opportunities in cancer among minority and medically served populations. And culminating our panel this evening is Dr. Eugene Manley. He is currently the Director of STEM Workforce at the LUNGevity Foundation, where he oversees Minority Scholars Training Program and other key health initiatives. He received his BS in Mechanical Engineering from Michigan Technological University, his MS in Biomedical Engineering from the University of Wisconsin-Madison, and his PhD in Molecular Biology, Cell Biology, and Biochemistry from Boston University. Here we go. We are so esteemed. As I say, it's an illustrious panel this evening. He has co-authored publications on gene therapy, combination drug therapies, and patient advocacy. Let's welcome our panelists, and it is up to you, Dr. Jeremiah.
All right, great. It's great to be here. Also great to be among my colleagues on the panel, and I am looking forward to the discussion that we'll have today. So what I'm focusing on presenting about is actually a program that has been implemented in and around here in Chicago, which is called the Citizen Scientist Program with a community-based organization called Project Brotherhood. And this initiative has been used as a strategy for engaging African-American Black men in the United States around cancer awareness and screening. So we know that community engagement strategies are critical to the identification of cultural beliefs and barriers. It also aims to achieve equitable, meaningful, and active community participation in all phases of community-based programs, as well as research. The benefits of community engagement approaches to research oftentimes lends itself to improving participation rates, increasing external validity, retention, and the development of individual and community capacity. So the Project Brotherhood initiative is a community-based health organization on the south side of Chicago that provides a holistic place for African-American men to receive health. Its founder and executive director, Marcus Murray, believes in the concept of the World Health Organization's broad and holistic definition of health and established Project Brotherhood under the principal idea that healthy encompasses complete physical, mental, social, economic, and spiritual well-being. At the core of Project Brotherhood, which we also refer to as PB, it asserts that health is a fundamental human right and an issue of social justice. Project Brotherhood focuses on creating culturally competent and respectful services with the engagement of multidisciplinary teams of nurses, physicians, social workers, administrators, men and women, all devoted to ensuring the multiple determinants of health that are converged to impact the health outcomes of Black men are addressed. So the Project Brotherhood is guided by what's the Murray model, which is defined after the founder, to increase equitable engagement of Black men in multiple levels of research designed to improve health. The model posits that interventions to advance health equity requires the integration of 4 fundamental tenets. The first tenet is the necessity of employing evidence-based practices for health prevention, screening, and treatment developed and evaluated with Black men. The second tenet is focused on community empowerment. Such empowerment builds on indigenous knowledge and leadership and approaches and emphasizes the inclusion of men as equal partners in the research endeavor. The third tenet of the model is the integration of Afrocentric and other culturally informed practices that fosters familiarity and pride among Black men. The fourth tenet is it relates to holistic approaches to health that moves beyond focusing on specific body parts, and instead it acknowledges the importance of the mind, body, and spirit in creating wellness. So Project Brotherhood has worked with several research enterprises to advance the principles of its community engagement model with an intervention strategy that focuses on training Black men as citizen scientists. Citizen scientists are laypersons who do not have formal science training, but receive training to engage in research efforts responsive to community needs. They're generally volunteers or paid for their time, and they're not formal employees of the institution that's conducting the research. The citizen scientist differs from community health educators who often have bachelor's level training or in health education or other specialized certification. They also differ from community health workers hired by medical and research institutions and receive on-the-job training to provide education or collect data in specific communities. Like the community health workers and the community health educators, citizen scientists' mission is to ensure the equitable engagement of community voices as staff educators or lay persons. The engagement of Black men as citizen scientists builds on previous work rooted in community-based work to assist in the recruitment and employment of healthy Black men. The term citizen, as noticed by Project Brotherhood, was selected to counter the often lack of recognition of the civil and social rights of Black men in America. It also fosters the concept of Black men in America reclaiming their citizenship and identity as an active voice in research and engagement to address historical misgivings about Black men in biomedical research. So Project Brotherhood developed the Citizen Sciences program as a partnership with the University of Illinois Cancer Center and Northeastern Illinois University, as well as Northwestern University to engage and inform cancer research initiatives and enhance cancer center research missions to partner with communities to improve cancer-related health outcomes and quality of life. The Project Brotherhood Citizenship Program involves a training that consists of fundamental issues around ethics of conducting research, health disparities, human subjects protection and research, as well as any expressed need or desire in knowledge and skills building unique to the citizen scientist's current environment. Individuals who complete the citizen scientist training are compensated for their time and effort. In recent times, the Project Brotherhood Citizen Scientist Program has been incorporated in 2 cancer-focused studies. Study 1 focused on prostate cancer, testing the novel biomarkers for prostate cancer screening, and several of the citizen scientists included 3 prostate cancer survivors, 2 faith-based leaders, 1 fraternity member, 1 civic leader, 1 barber, and 1 social worker. In the beginning, the cohort of citizen scientists all had elevated mistrust about healthcare providers and researchers, but the training and the engagement of them in the citizen scientist program shifted their perceptions as they welcomed the opportunity to engage in advanced prostate cancer screening. The other initiative that we also have worked on is the SHARED project. It's the acronym stands for the Supporting High-Risk African-American Men in Research and Engagement in Decision-Making. And this project rigorously engages Black male citizens, scientists to increase the cultural targeting and implementation and evaluation of evidence-based practices to improve lung cancer screening. The citizen scientists have been involved in the data collection, analysis, and includes the adaptation of a decision aids that will enable providers to succeed in getting more African-American men considering lung cancer screening early on in their lives. So as part of my current work that I'm doing also with the National Cancer Institute and the Informatics in Technology for Cancer Research Center, we are also embarking on an initiative to offer training the trainer opportunities, particularly targeting minority-serving institutions, community-based organizations, communities of color, HBCUs, as well as Hispanic-serving institution. And what we've done is we've actually partnered with the citizen scientists and the cancer informatics instructors to focus on the integrated use of citizen scientists and informatics as models of engagement for research and practice. This program is facilitated by Project Brotherhood, along with community advocates, researchers, and practitioners. And we are actually launching our first initiative on August 26th from 9 to 1. Here's a look at the flyer that we'll be doing. This initiative will be online for the first time. And each participant who decides to participate in this training is compensated for $250 for completing the workshop. And we are looking for new partners as we are having some discussions with Morehouse School of Medicine around launching this initiative also down in Atlanta, but we are willing to go nationally to any institution or partner that is willing to host us as we deliver this program, both virtually or in person. So if you have any more information, feel free to reach out to me or to Marcus Murray, and be happy to share more information if anyone has any questions.
Save the questions to the end of the presentation, and all the panelists have presented. If you have any questions in the interim, please look at the bottom of your screen and place your questions in the Q&A chat area. Again, we will answer your questions culminating the panelist presentation. And the next voice you will hear is Dr. Desiree Rivers.
Everyone. Thank you again, Dr. Standifer, for this tremendous opportunity. This evening, I will be sharing with you a project that we have ongoing in a partnership that is longstanding between the Morehouse School of Medicine, Tuskegee University, and the University of Alabama at Birmingham. The project is entitled Racial Disparities in Lung Cancer Screening Among a High-Risk Population at a Community Hospital and Academic Health System in the Southeastern United States. Again, I'm Dr. Desiree Rivers at Morehouse School of Medicine. I'm joined in this work by a partner, Dr. Naranjan at the University of Alabama, Birmingham. And that will become more significant to you as we go along while we have this dual partnership. Again, thank you for this opportunity. Dr. Standifer shared some background on lung cancer, and I just want to add to that in framing the issue. We do note that lung cancer is a leading cause of cancer death in the United States, that currently high lung cancer incidence, both in terms of who has lung cancer as well as mortality rates, have been attributed to high smoking rates. And that's significant in the populations. So of underserved, low income and rural populations, this is the case. We also note that disparities in lung cancer mortality, so those who have unfortunately succumb to lung cancer, are more pronounced between rural versus urban residents. Possible explanations include increased tobacco use and a preponderance of late stage diagnoses following lack of uptake of screening. And that's where this work begins, that we wanted to look at the current screening guidelines. At the time, we were still under the auspice of the 2013 guidance from the USPSTF, saying that persons of the age group of 55 to 80 who had a smoking history of greater than 30 packs per year and who currently smoked or quit smoking within the past 15 years would then be recommended for lung cancer screening. There has since been a change, and we're actually very fortunate that that change is now ensued, that we have lowered the age to include those 50 to 80, those who have a smoke history of greater than or equal to 20 pack a year, and the same current smoke or quit smoking within the past 15 years. And the particular screening exam that we're looking at is the low dose CT. And there's a number of advantages to that particular type of screening exam. In the specific study that I'm going to address tonight, the aims include looking quantitatively at who is being screened. So what is the uptake of lung cancer screening in a high-risk population in using medical record review in two very different systems, one being the University of Alabama at Birmingham, specifically the Kirkland Clinic, and then the other being the Grady Hospital Lung Cancer Clinic. For the Grady site, just in Atlanta, that would be considered our community facility. And then for the University of Alabama, Birmingham, the Kirkland Clinic has the support of, it's considered an academic center because it has the support of a comprehensive cancer center. And so that would be the first aim, to quantitatively assess. So how do we identify how many folks are being screened for lung cancer in those two settings? And then our second aim is to qualitatively explore. So what are the barriers? What are the facilitators to folks obtaining the lung cancer screening as recommended, again, in the two sites? And we do that by a series of focus groups with patients and key informant interviews with healthcare providers, ultimately with a plan to integrate what we've learned in terms of the number of folks who are actually being assessed for lung cancer screening, what they identify to be their barriers and facilitators to that, to then design a culturally appropriate psychoeducational intervention that would address lung cancer screening among this high-risk population of African Americans in the deep South of Alabama as well as Georgia. Thus far, we are undertaking aim one. So to address, again, the quantitative assessment of uptake of lung cancer screening in these two populations, we have reviewed the electronic health records for participants at University of Alabama, Birmingham, as well as Grady. The time period that we looked at was as far back as January of 2015 to December 31st of 2020. We looked at a cohort of individuals eligible for lung cancer screening, again, based on the guidelines in the two institutions, University of Alabama, Birmingham, as well as Grady, and then examining those factors associated with uptake among that particular population. Eligible participants were again based on the 2013 guidance of those ages 55 to 80 without a diagnosis of lung cancer, but with the appropriate smoking history. What we've done so far, again, in both sites simultaneously, we've received and analyzed data. The data is actually a little bit further along in terms of what our analysis in the Birmingham site, but at the Morehouse site, at the Grady, that data is being currently analyzed. Another sort of outcome of this work in sharing it with the community is that we have actually had a request for this project in a local site, so in a rural site, which would be the Phoebe Health Center in Albany, Georgia. And so I just note that to share that we are spreading the word about this work, and we will consider inviting other partners to participate. And then jointly, what we've done thus far is present this work again in other settings. So both in the community as well as at a national conference, the ASCO Quality Symposium. And there are absolutely plans for us to jointly develop what would be the interview guide that will be used at both sites in terms of collecting the barriers and facilitator data. Just to give you a preliminary look at what we found so far in the data, just so you have some sense of who we're talking about and what the population looks like who's been involved in this work. So again, for context, we're looking at those who are eligible to be screened for lung cancer from the time period of January 2015 up until December of 2020 at the University of Alabama, Birmingham. In a cohort of about 67,000 individuals, again, identified as eligible, so they should be getting the recommended lung cancer screening. We only see about 1,100 or so screened. 16 individuals were identified as not being Alabama residents, so receiving care in Alabama, but not being Alabama residents. So therefore, they were actually not included in our analysis. Then the remaining 1,129 individuals that were screened, we see that their age is about 67 years, mostly male and mostly non-Hispanic white. And I'll just stop there to share that that is what we expect to be an older population, perhaps, than what we think that we're going to find with the Grady population. And again, a larger non-Hispanic white population than what we expect to see at Grady. When compared to those not screened, those that are more likely to live in an urban area. And then compared to those not screened based on the miles away from the care site of UAB, those screened are more likely to live closer. So live closer in an urban area, you're more likely to be getting the recommended screening. I shared this information to put it in the context of, yes, this is a lung cancer project, it is an intervention, and it does not specifically address a clinical trial, but I think many of the same infrastructure that we have in place for this work would be supportive of the larger discussion related to participation in clinical trials. What I mean by that is that this lung cancer project is operating in the context of many of these listed resources. So there are active discussions, feedback, guidance that is provided to us in this project from a bioethics lens. So we have partners at the Tuskegee University Bioethics Center who are investigators, who are part of this work, who guide us, again, in the specific ways of our participation is required in many bioethics education and workshops. And again, that's important in terms of looking at the broader context of this discussion related to clinical trials. We want to address ethics, and we want to address bioethics specifically. Another one that I'll note is that, again, this work is taking place in the context of working very closely with a very active outreach corps. What I mean by that, again, is that there is a very active participation on our part, as well as on the outreach corps, to include us in many of their awareness and education activities. So again, it is just as important for us to spread the word, to provide education and information about the global topic of research, of participating in research, participating in cancer research, participating in cancer services and clinical trials. And that is an active part of what we do with this work. not necessarily part of the aims, but we know how important it is working with the particular populations that we work with, that we do these things. And then finally, I'll just note the Research Education Corps. Again, very involved in the training and education of future generations. So many of our research partners and research team are trainees, and so they're also involved in this work. And so we do note how important that is to involve trainees in this work. And then finally, excuse me, where we're headed with this work is what we hope to do is to then be able to adequately characterize, describe, quantify even what's happening in terms of lung cancer screening at two very different health systems. We think that that's significant, that we understand what would be the benefits, what are the things that we can take and learn from maybe an academic health center that could be applied to a community setting, and then vice versa as well. There are many things that could be learned from the community setting and how to work with underserved populations that then could be applied in an academic health system. In our second aim, our second objective, we do hope to also determine what are those reasons. So what would inform optimal utilization of the guidelines for lung cancer screening? If they're not in place, what would make them be more likely to take place? How can we optimize that? And then finally, our ultimate goal is to then develop multi-level interventions. Again, understanding that this is a multifaceted issue, and that if we're going to adequately address it, if we're going to involve work that is going to be beneficial to this population, then we must have interventions that address not just the patients, those that are affected directly, perhaps from lung cancer, but also providers and then systems as well. Thank you.
Well, thank you again for a very robust presentation, Dr. Rivers. We will now hear from Dr. Manley.
Good evening. Thank you for inviting me here, Dr. Standifer, and I'm very honored to talk about some of the health equity and mentorship programs we are doing at LUNGevity. And I'm going to share the screen. Else has already given an overview of a lot of the lung cancer disparities and rates and programs that are trying to address issues in the community. I'm going to talk more about health equity education and some programs that we are doing to train the next generation of minority health equity scholars. And so I wouldn't get so worried about all the detail on the slide. The key things I just really want to point out is that LUNGevity is one of the largest lung cancer patient advocacy organizations. And the purpose of the org is to have a world where no one dies from lung cancer. And we do this through several ways. One is through funding research, often in early detection, clinical trials, biomarkers. We conduct patient-focused research to understand unmet needs and barriers. We also empower patients through online peer groups, providing educational materials and in-person survivorship conferences to sort of give them materials and education that can help them as they navigate their diagnosis and survivorship. And we do a lot of research publications across the lung cancer care continuum. And part of the stuff I do a lot of it is in the health equity initiatives and STEM outreach and mentorship. And just briefly, I'll talk about that we have 3 health equity webinar series. One is an internal series called the Health Equity in Action Speaker Series, and it's more, it's a thematic theme every year. So it's this year's theme is related to screening, biomarkers, and early detection. And so we have speakers that are not just doing work in the communities, but also understand the communities, understand their needs, and they're doing community involvement to get involved in the research and not just come and do a study but no, how do they engage? What can we learn? What are best practices? The second one is Conversations That Count. And this is more a more periodic session. It's related to the health equity months. And this is more where we have a patient voice and typically either a researcher or a clinician. And we sort of get that patient to talk about the issues that they face and how their community can learn how to navigate lung cancer. And then the series that we just started, well, this week and next week, is the Spotlight series, which is a brand new series. And hopefully we'll start getting these on the website next week. And the Spotlight series is designed to really highlight issues in lung cancer and thoracic oncology that often are missed by the majority of the population because they don't sort of see the issues that affect minority, underserved, invisible communities or those of health equity or disparities. So really trying to have different conversations about the different barriers and impacts and what we can do, learn, and make improvements. And this series will start showing up on the website next month, and it'll be monthly. And it's more like a fireside chat, and I'm limited to speakers. So like 15 slides to show the key data about the disparity, but really educational pieces so that people can go view them as necessary. We've created some academic partnerships to sort of work and train the next generation of underrepresented scholars. And so we have a partnership with Temple University where we funded some minority first-gen students to do summer research projects after their first year of med school. And so they just did small 6 to 8 week projects. Some of these were surveys, some of these were developing an app, but the goal is to give them exposure to thoracic oncology at early parts in their medical career in the hope that down the road, they will consider thoracic as a specialty. And then with Mercer University, we had a partnership. Well, I served as a preceptor for their inaugural Doctor of Public Health student program. And since those students are in Georgia and part of that focus is on health equity and disparities, I crafted several projects that are related to lung cancer, specifically in Georgia. The big other initiative that we're working on that will launch next month is the Minority Scholar Mentorship Program. And it's really an add-on program for our Minority Health and Inclusiveness Research Grant awardees. And these awardees are postdoctoral fellows, clinical fellows, and early career faculty. So they are finished all of their training are in the first 5 years of their faculty roles. So more generally, the goals are to provide training in thoracic oncology from a health equity lens, provide training in grant writing, review, and submission, provide ancillary skills, a lot of these wraparound skills that a lot of underrepresented scholars, first gen, don't know, like retirement accounts, negotiating contracts, moving expenses, etc. Provide them multiple external mentors to reduce dependency on one professor, exposure to alternative career paths in case they do leave science or medicine. But ultimately, the goal is to increase workforce diversity by increasing the number of people that we get funded, who then can advocate for other minority researchers that are coming along. And secondarily, if we can get them to stay in academia, they can become in leadership positions, but also change the workforce diversity, which is very non-diverse. And if we can do this, then we can hopefully increase outcomes for minority patients, because then they will have more trust in the people giving them care, and the care can more hopefully closely reflect the populations with the highest incidence and worst outcomes. And so what we sort of, how I framed the program is trying to address some of the hidden issues that prevent the advancement of minority scholars. So a lot of these are barriers, support, holding people accountable. And I'm not talking about the trainings, I'm talking about people that are in positions of power that control how they can grow and flourish, providing networking, because often as a trainee, your ability to network is sort of dictated by who your professor lets you interact with and not vice versa, not them leading you. And then providing these layers of mentoring. And so I sort of sketched this out today to put more color to the slide, Dr. Standifer, because and so the real sort of, the way you think of it, they get a health equity and inclusive grant award. And then we sort of put this, generally 5 buckets. So they're going to all this training in thoracic oncology from a health equity lens. So this means that we're teaching them to look at thoracic from the lens of those that are marginalized, excluded, and not routinely in the workforce. So as you think of doing any study, whether it's basic, clinical, translational, or communications, how do you understand and account for or think about minority and invisible populations? Are you running a trial that has patients and like you have 10 Black patients, oh, we're going to toss it out because the data is not clean. Nope, you got to then figure out why you don't have those Black patients or those Latino patients in the trial. You can't just toss out data. And so this is what all people in thoracic oncology should be learning, not just our trainees, but this is where we start. They're going to get this training in this grant writing. So all those concepts from the health equity lens will go into them working on a grant proposal that we want them to submit in 1.5 years to a funding agency. Like I said, we'll give them multiple external mentors. So these are people with different competencies and skills that will help them in different aspects of their professional growth. Like I talked about the ancillary program that will cover aspects of professional, career, life, and personal skills. And then really doing this networking to build connections between the scholars, to help them build a community and to help them understand how to give back and what to look for as they grow professionally. So right now the program is designed to, without getting into super detail, there'll be 11 monthly webinars that'll weave the health equity into the grant writing. They'll have quarter ancillary courses. They'll have 4 mentors. And then they'll have this in-person session to really finalize the program and do mock grant review so they can get that feedback to make that grant something they can submit. And so if we think of it as an onion, we'll have the minty and orange in the bottom. And we think we have a lot of the stuff is going to be virtual until the in-person session. So a lot of it is e-mentoring, but we know the senior faculty mentors will do group mentoring if they teach a course, but also that electronic mentoring. They'll have a lot of one-on-one with their junior faculty mentors. So they'll get someone they'll meet with for an hour, once a month or twice a month for half an hour. So that's that direct contact time that many scholars don't get. I'll be meeting with the scholars every quarter because the other problem is many programs will give you funding, but then you don't hear from the grant office until that 1-year report is due. But when you write that report, that doesn't mean that you're writing that report. That could be you or the professor, and then but the org and the funding agency doesn't know if you're in a place that is allowing you to grow or flourish, or if you're just going to tread water. And then last, like I said, we'll have the peer-to-peer mentoring. So they have give them a Slack channel or something so they can form the networks with each other. And then as they come out the program, do near-peer mentoring so they feel they can give back and give the new trainees experiences they learned and why they feel the program is important. And so what's unique about this is that we're ensure that these minority and marginalized populations are thought about through all stages of research design. The multiple mentors will reduce dependency on one professor. The periodic meetings with awardees will ensure they're seen and heard. It tackles the fundamental issues that often hinder career advancement. It doesn't tackle all of them, but it tackles a fair number. And I'm really excited because this first cohort of instructors come from 11 different institutions, including 2 HBCUs, and it's a balance of people that are identified as Black, Hispanic, Asian, Indian, and white. That was not intentional, but I'm happy with that. And sort of just, I know we're almost out of time, but just really the sort of broader goals, short, intermediate, and long term are just to evaluate each session, see how many gets grants, how many gets funded, how many become faculty, how many get promotion and tenure, and really do the more qualitative things like, do they feel the program meets their needs? Do they feel seen? Do they feel respected? Do they feel they have a voice? Often things that aren't assessed, and really accept the feedback they give to help refine the program as it grows. Because ultimately, while we're starting with our funded scholars, in 5 years, we would love to have it to a spot where we could also run the program for those that don't have funding, as long as their institution supports it. And so what we really want to accomplish are increasing mentorship and support of these scholars to increase the numbers that stay in thoracic. Like I said, through increasing the workforce diversity, we can have a workforce that looks like the patient population with the highest disparities and worse outcomes. And then the patients that feel seen and respected. And then, as we know, an increasingly diverse workforce is more likely to have cultural competency and be able to educate patients about clinical trials, research, clinical trial participation, and may help guide or lead to more specifically targeted therapies for minority populations, because it's really frustrating for us to see lot of immunotherapy drugs come out for lung cancer, and less than 3% of the patients in the trials are Black. And so, well, how do we know this will work in this community? And this is my contact information. And with that, I think I'm done. And I thank you for allowing me to present.
Thank you, Dr. Manley. Thank you, everyone. Superb presentations. I don't see any questions right now or any additional feedback. I would like to close with a few final slides, and then I'll turn it over to Pat Sanders, and I will share my screen. And again, I would be remiss if I did not get a chance to, again, continue to talk about LUNGevity Foundation, who I am, Dr. Eugene Manley talked a little bit about his role, but I am currently a community scholar in residence with LUNGevity Foundation. The foundation, as Dr. Manley mentioned, is committed to ensuring that all people diagnosed with lung cancer have the same opportunities for best case outcomes and access to trusted resources, regardless of race, ethnicity, gender, sexual identity, age, socioeconomic status, or geographic location. Again, it's an honor to be a part of the foundation, where we are continuing to amplify the message of equitable solutions and health outcomes with lung cancer, specifically, and even more so with treatment opportunities and biomarker testing. We're ensuring that research is impactful by partnering with patient groups like ALK positive, or a group of ALK positive patients diagnosed with lung cancer in over 41 countries, raising significant funds for research into the specific biomarker, focusing on the patient-focused research center, which is called Patient Force, changing the paradigm in lung cancer from assumptions being made about patient preferences to evidence-based conclusions about the value of patient care. And LUNGevity is always researching new ways to reduce health disparities in lung cancer through our community-based participatory research program, bringing together researchers and community stakeholders as equal partners. And I am also assisting with creating the first health equity and policy roundtable that will be held this December. Again, if you need more information, you please feel free to connect and link with lungevity.org. Again, we'd like to talk about the next month, which is November. November is Lung Cancer Awareness Month, as some of you know, and some of you may not know, but we know this month is, October Breast Cancer Awareness Month, and we want to continue to highlight within our community-based settings, but also academic and research-based settings, and even faith-based organizations, to highlight what is really impacting those who are marginalized, those who are medically underserved. And as our panelists highlighted, thank you so much, Dr. Rivers, Dr. Jeremiah, and Dr. Manley, the importance of having that voice and that face that looks like you, conducts research with you, and is able to talk with you along the journey from pre-treatment or pre-diagnosis all the way through treatment. So whether it be increasing the training opportunities for researchers, for community health workers, navigators, as Dr. Jeremiah highlighted, creating those clinical outcomes, as Dr. Rivers talked about, and even going into those mentorship opportunities, as Dr. Manley highlighted. Again, I would be remiss if I did not highlight Emmanuel Standifer Jr., and is known as my husband, who succumbed to cancer last year, April 11th of 2021. And for this, this is purpose, I am here. I am continually committed, dedication, and forever passionate about lung cancer and reducing disparate outcomes, specifically in African-American population. And I really wanted to highlight his podcast that he created right after his diagnosis, Folk, I Got Something to Say, which he wanted to amplify his journey through cancer diagnosis, and being my husband, him being a father, and him being a faithful leader at church. And so again, I would be remiss if I did not thank the panelists to continue to amplify the message of engagement, trust, and having value in research when we're talking about clinical trials. and to 50 Hoops, who continues to support me and advocating and naming me as a legend, and to Mr. and Mrs. Sanders, who again, who without I would not be here. I thank you again, and I'll turn it over to Pat. Thank you.
Dr. Standifer, you can select someone for the gift, for the $50 gift card from the guests, if you would.
All right, so I have to look at the guests.
Pick a card.
I will pick a card now. I know my grandfather is in there. He was on the screen for a while, Mr. Carl Jackson. So that I had to just say I won't pick him because he'd probably put it back in. But let me see a name that I don't recognize. Let me see. I see Sakith Nadimpali. So that is who I choose randomly. Thank you.
Keish, could you send an email to PSOC@yahoo.com with your address, and then we'll get you out your gift card. And we can close it out with Dr. Reverend Singleton, if you would take us out.
I'll be glad to. Let's bow our heads once again. Lord, it's just an honor once again to come to you just to say thank you for another day. And then, Lord, we pray that the information that we have received this evening, that we can go out and share with our families and with our communities, because it's all about helping others. And now, Lord, as we dismiss from this meeting, under no circumstance do we dismiss from your holy presence. Lead us and guide us and protect us. And we will always give you the honor, the glory, and the praise. In Jesus' name, amen.
Wonderful job. I am overwhelmed. Desiree, Jeremiah, Eugene, ooh, you have taken my breath away. The complexity, the depth of what you guys are doing is just outstanding. You are the future. You are the future. God bless all of you. Have a good weekend.
Thank you so much.
everyone.
Tremendous opportunity.
Have a great evening.
Yeah.